Again, the article is Whiplash, Real or Not Real, a Review of a New Concept. They state, chronic whiplash is symptoms that persist for 6 months or longer. 50% of those who are injured in whiplash develop chronic symptoms. Classic chronic whiplash symptoms include neck pain, headaches, interscapular pain, paresthesias in arms and hands, dizziness, TMJ pain, visual symptoms, vestibular symptoms, cognitive problems, and emotional/psychological disturbances. In some patients who experience an unexpected rear-end collision, the symptoms persist for years. All right, that is a key point. All right, we've talked about this multiple times. Getting hit where you're unaware of the crash is the worst thing that can happen to you. The surprise is what gets you. All right, an essential factor in chronic whiplash is whether or not the driver in a rear-end car crash is aware of the impending collision is extremely important. The awareness or expectancy of the incoming collision is crucial in the whiplash process. 70 to 80% of the patients suffering from chronic whiplash were unaware of the incoming collision. A correlation exists between being unaware of the incoming collision and a poor recovery. A crucial factor in determining the extent of whiplash mechanism injury is the expectancy of incoming collision. Another key point, more women suffer from whiplash trauma than men, 1.5 to 1. And more women develop chronic whiplash symptoms than men, 1.54 to 1. The literature says a lot of that could be from the diameter of the neck. In a woman, it's going to be smaller than a man's. A number of lines of investigation have documented the following injuries from whiplash mechanisms. Number one, facet joint capsular ligaments. That's a really big one. Paravertebral ligaments, including the anterior longitudinal ligament, intervertebral disc, dorsal root ganglion. The dorsal root ganglion is the little relay center. The nerve exits the spine. So the nerves exit the spinal cord, and that bump right there, that is going to be your dorsal root ganglion. So the nerves sort of relay center for the nerves. All right. See that? Can you see that, Ed?
Yes.
All right. All right, Kevin's got it too. Neck muscles. Fatty infiltration of the muscle is considered indicative of pseudohypertrophy and is extensively demonstrated in chronic stages of whiplash by MRI studies. Very important point here. Current diagnostic techniques cannot detect tissue damage in chronic whiplash patients. So this means your typical stuff. This is like in a plain MRI, plain CAT scan, plain X-rays. But there are something called a stress X-ray where you can see this injury. All right. The stress X-rays, when you take the X-ray with the head flex forward and the head back, and you do a measurement. And if those bones slip more than, in the cervical spine, slip more than 3.5 millimeters, that is going to give you documentation of ligament injury there. Now, the research says 1 millimeter is normal. So anytime you have more than 1 millimeter of slippage, you have an injury. You can document the injury very well. And that's one of the things that makes docs in my group special, and that we really focus on this injury, because the powers that be know that this is an important injury, because what happens is the spine is never going to recover from that injury, right? These injuries do not heal, they wound repair. And they wound repair with scar tissue. Scar tissue gets in there and it causes all sorts of problems. The bones don't move properly, it creates abnormal loading, it creates abnormal stress in the area, it creates instability, and that area is never going to be the same, and it's going to speed up the degenerative process. The literature is clear that once you get one of these injuries, the degeneration in your spine accelerates by over 50%. So this is the long-term sequela. Now, the other part about this is that if you look in surgical guidelines for the spine, you will find that if they see that 3.5 millimeter slippage, that's a surgical case. You can go to any spine center and look and say, you know, what's an indication for a cervical spine surgery? This is it, when you have 3.5 millimeters worth of slippage. In the lumbar spine, it's 4 millimeters. In the rest of the spine, I think 4.5 millimeters at the base of the spine. So this is a very common procedure, but it's been missed in the literature for whiplash, and that's one of the things people in my group are good at. The other measurement they take is they do what's called angular rotation. which is how the bones angle from one another. All right. The normal degree of measurement is 7 degrees, normal angulation. And if it's more than 11 degrees, that's going to give you a instability, and most importantly for your case is the impairment rating. All right. The computer algorithms that they use, the Colossus programs, as you're familiar with, I'm sure. There's 4 parts to it. Insurance settlement. There's the injuries, there's the impairment rating, there's duties under duress, is what you can do when it hurts, and then there's functional loss, of what you can't do. So unless you get the impairment rating, it's very difficult to unlock the bottom 2. So the impairment rating is a key thing to get the maximum value in your cases. All right. So moving right along, standard imaging techniques such as radiography, computed tomography, CT, or MRI inconclusive of the prognosis of the symptoms after whiplash trauma. PET imaging, PET, positron emission tomography, with inflammatory markers show chronic whiplash patients have persistent inflammation around the neck muscles as compared to controls. Now, this is not a standard test you would probably order in most cases. The initial whiplash injury is the inertial reaction creating a non-physiological S-shaped spinal curvature occurring where the entire cervical spine column is under compression. Whiplash injury. Oh, we got on. Whiplash injury occurs during the S-shaped phase and usually involves a subject who is unprepared for the incoming collision. All right. Yeah. Just upstairs and grab one. I got it right here. All right. So just to review, you guys are experts in this, but just to show the picture. Okay. All right, you see the 4 phases of a whiplash injury. All right, phase 1 is in my right-hand side. You can see the occupant of the car. What happens is the car slips underneath the person here, and your head and body start to ride up. And at some point, you stop riding up, and then the car moves the torso forward, and the head goes back. This is where the injury occurs, right? Because one part of the spine is going forward, and the head is going backwards. So the head's sort of like staying in place, but the body's moving out from under it. And then everything starts going backwards, and everything slips forward. All right, so there's your 4 phases of a whiplash crash. And that number 2, this guy right here, that's where the injury occurs. That S curve. Symptoms after a whiplash injury result in disturbed proprioceptive information from the neck. All right, another key point. When you move, your spine has these receptors called proprioceptors, and it basically gives the brain information where your body is in space. So if everything's healthy, you get a proper flow of this information to the brain. When you get a whiplash injury, that message is going to get static to it. And that's going to cause imbalances in the musculature, imbalances in the rest of the spine and nervous system, and it's going to create a vicious cycle of bad stuff. There's a close interaction between neck proprioception and mechanoreceptors, and with the brainstem controls of vision, vestibular, and somatosensory functions. So vestibular is going to be your balance, vision's obvious, and somatosensory is, again, where the body is in space. Anybody need any clarification on that? Everybody with me so far?
Yep.
All right, good. All right, chronic whiplash symptoms are a result of mismatch between aberrant information from the cervical spinal cord and the information from the vestibular and visual systems, all of which are integrated in the mesencephalic periaqueductal gray and adjoining regions. So that's just a big word for the gray nervous system inside the brainstem. The upper cervical whiplash injury derives an alteration in proprioception and mechanoreception, or result in altered pain perceptions, depressive-like symptoms, headaches, TMJ symptoms, dizziness, visual disturbances, alterations in postural control. More than 30% of the spinal periaqueductal gray fibers originate in the C1, C3 spinal segments. All right, so That top of the spinal cord is where the mother lode of these receptors live. The researcher on this who really did this was a lady by the name of Dr. Candace Pert, and she was at Georgetown, and she was actually a psychiatrist, and in her research, she figured out a lot of these receptors, not only for proprioception and mechanoreception, she found that there's a big emotional component to those receptors. The group of neurons located in the periaqueductal cray are involved in a number of individual and species vital functions, including pain, modulation, micturition, which is going to the bathroom, blood pressure, flight or flight response, sympathetic nervous system, vocalization, respiration, and mating behavior. There is no clear evidence to support that compensation and related processes are involved in the health of whiplash injured patients. Number 18, these authors propose that chronic whiplash symptoms, nausea, dizziness, headache, neck pain, are due to an injury-induced mismatch in the midbrain and other structures via the upper cervical cord to the middle of the brain, and on one hand, and the intact information from the vestibular and visual symptoms to the midbrain on the other hand. The subsequent continuous imbalance may create a permanent hyperarousal of the brain, depending on the strength of the cervical damage. So this is why the chiropractor has a big leg up in these cases, because the chiropractor is the one provider who can rebalance these receptors. All right, so the study supports the evidence that concentrating on pain control with drugs is misplaced in the whiplash injured patient. The evidence continues to support that chronic whiplash occurs as a consequence of poor quality proprioceptive and mechanoreceptive input from the injured soft tissues into the central neural axis. And the management should be directed towards improving mechanical function of the injured and often already repaired soft tissues. This very much supports the chiropractic approach to the management of chronic whiplash patients. So that's why the literature says that going to the chiropractor is the best thing since sliced bread for these injuries. Because you got to, unless you can get these guys moving again, you just can't get them better. All right. Questions? I know there's a lot of big words in that one. So shoot.
When you talk about receptors, I don't know what those are. Like, is that something you find in a muscle? Is it something you find in a ligament? What is it?
All of the above. You find it everywhere. All right. A sensor would be a good sensor is a thermostat. All right. Your thermostat in your office there is a sensor for the temperature. All right. And your body has these sensors for movement. Your body has these temperatures for feel and for touch. They have receptors for in your ears to hear, receptors in your eyes to see. So these receptors are numerous in the body, and these receptors are numerous in the body and have all sorts of applications. Now, in this case, we're talking about mechanoreceptors in the muscles, the ligaments, the joints, the discs, and these mechanoreceptors are what's allow you to stand in space, allow you to move.
And can you see damage to a receptor on any kind of a film?
They're really, 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 no, you can't. They're really, really, really tiny. I mean, they're tip of a pin kind of tiny. So you're not going to see those. I mean, if you really wanted to, what you could do is you could take the tissue and stain it, put it underneath the microscope, and you'd see them. But again, not something you would do. You could, but you can test that, all right? And you test it, have someone stand in place, close their eyes, and just stand there, all right? Now you're testing the mechanoreceptors because you're taking the visual cues out, and now you're just dealing with the body's ability to balance. So that's one of the tests you do. It's called Romberg's test, right? Have the patient stand up, close your eyes, and you put your arms around them, because if these receptors are shot, they go and tumble right over. There's a test that I use for concussion patients. That's the same kind of thing. It's called the sway test, and it documents the level of proprioception function in the body. So the passing score on this sway test is an 80. Typical of my concussion patients are 50 and below. And below. So the Romberg's test is just a test you do with the person standing there. Sway test is an app on my phone, and it measures the movement of the patient. But it's a great test to document concussion. The NFL is using it now It just makes my life a lot easier, because every checkup, I do my checkup and then I do the sway test, and I can effectively document how that patient's brain is recovering from their injuries. Yes, very objective. Kevin says an app on a phone, nice and objective test, so you can graph, the patient's recovery. So I had a young lady come in just about 4 months ago. She's coming up on a 4-month checkup. She, during a celebration with some alcohol involved, fell and gave herself a concussion. And she's seen a whole bunch of other providers. And we came in, did the sway testing. And what was interesting in her case is that she was doing well, progressing, but slowly. And I happened to come across an article that said that brain function has blood pressure has a big determinant on brain function. And especially if you have low blood pressure, your brain is not going to function as well. So people who have low blood pressure have a tendency towards Alzheimer's. So I'm thinking, this lady has really low blood pressure. I mean, she was like 90/70. Right? Typically, it's 120/80. So I'm like, let's try something. So I tell her to go home, and I have her do a half an hour cardio every single day for a week. What does cardio do? It's going to get your heart pumping, right? Get that blood up to the brain. And sure enough, at the end of the week, she was feeling like 20% improved in 1 week, because we were able to, we located that one area of weakness with her and snap right back. She felt so much better after 1 week of doing cardio 30 minutes a day, just because we got the blood pressure back up. Cool little clinical tidbit there. Any other questions?
Early on, you mentioned that you could diagnose damage to the ligaments doing those flexion extension x-rays.
Yes.
And the people that have whiplash that you treat, I mean, what percentage would show up as 3.5 or greater? Is that?
My guesstimate is about 70% of your female patients, about 50% of your male patients.
Oh, okay.
So it's a big percentage.
So it's definitely worth having them tested with that.
Absolutely.
And do you have to do it soon after the accident, or would that show up even if they've been treating with physical therapists and other kind of things?
The way it works is this: it depends on the patient. If you get a patient that really sore and stiff after an accident, not best to do it then, because they're sore and stiff, like a muscle spasm, the splinting going on to protect the movement. So typically with a patient like that, I work for them for like 2 months, and then I do the test and send it in. 2 months to get the muscle spasm out of there so you get a real good picture. So if they don't have that, I'll do that right away. So I had a young lady, she was sitting in her pickup truck and a guy slammed into her pickup truck. I did it on her right away because she didn't have that muscle spasm, that splinting. So she was someone, I'll send it in. We already sent the test in. She was a new patient last week. So that's because, again, like I said at the onset, these ligaments do not heal. Right? They get gunked up with scar tissue, just like any scar, and they don't allow proper movement, creates instability, and that's why you have that advanced degeneration, and that's why you get that big impairment rating. All right, with the 5th edition impairment, when you get that 3.5 millimeter slippage, it's a 25% whole body impairment. That's worth real money in a legal case. I had a case, a judgment in a trial, $60,000 for a ligament injury case with no other medical professionals. Now, I wouldn't do that on a regular basis. It just happened to work out with that particular patient. But no orthopedic care, no MRIs, just that ligament test. We had $60,000 on a rear impact. And that's the number that the insurance companies reserve when they see that diagnosis. So if you got that ligament laxity thing, now obviously, if you can get other testing on it, great. But the fact is, that alone is a big finding. And how many cases have you had where you didn't have that test to have in your pocket to go deal with that insurance adjuster? And Kevin's on the call. I had a case with him. We used that, and we got a good result out of that case. I don't think that one went to. I think he just settled that one, if I'm not mistaken. But that is in these whiplash cases, that is the key finding. If you can get that test, then you throw an MRI on top of that. You had some good documentation of the injuries. Now you're talking real money for these whiplash cases. You know, you don't have to worry, you know, take those low ball offers and tell them to stick it. Quite frankly. Good. Any other questions? Good, great questions, guys. You know, this article is not particularly in the Kevin's asking if is the material in the book after the car crash. It is not. I'll have Jack send around a copy of the email, copy of the article in an email. But it's from Pet and Spect in Neurology, 2014, pages 947 and 963. And obviously, these guys like to use big words. So if you have any questions about the translation into English, I'll be happy to do that for you.